Hi, welcome to another episode of Ad Hoc with the Doc. I'm Dr. Dan Rubin, and I'm here today with a longtime friend and colleague, Dr. Belinda Barclay-White. We both practice in Scottsdale, Arizona. Dr. Barclay-White is a breast radiologist and has long time been somebody that we've worked with and advocated with, and I'm so excited to be here to talk to you about breast radiology, mammography, cryoablation of breast tumors. I know our audience is going to love this episode. I wanted to thank you for being a friend to naturopathic medicine for all these years and all you've done for the community of women in Scottsdale. It's been wonderful. People just say the greatest things about your services, so it's been my privilege to work with you.
Oh, you're making my head swell. Thank you.
Thank you.
Thank you very much.
I do want to ask, why breast radiology? Why so specific of an interest?
So I was a general radiologist in a group of men, basically, when I came to Phoenix, and I was so struck by how badly breast imaging was being done, and as a woman, I really felt that we needed to improve on that. So I was encouraged by my partners to go into breast imaging as the only female in the group, and I quickly became really sort of enthralled with it, and I educated myself with all the local conferences and all the national conferences and became very passionate about it, and then decided that practicing in the hospital setting, there was only so much I could do to make it a more positive experience having a mammogram. So I actually opened Breastnet 20 years ago.
Breastnet is the name of your practice?
Yes.
That's Breastnet,
yes.
Right here in Scottsdale. Well, interesting. Mammography. I, for myself, have not really been able to sort out the different articles and statistics, coming out about mammography, but specifically the guidelines. I'm confused, which means that probably the public may be confused too as to what the guidelines are. Can you talk a little bit about current guidelines for mammography for detection?
I certainly will. So there's so much confusion about guidelines. And my patients are definitely confused. They ask me every year because it's changing on a year-to-year basis. The referring physicians are very confused. Some of them are actually telling women, no, you don't have to screen maybe every couple of years. Over age 65, they're being told they don't have to screen anymore. The issue is that breast cancers in young women are not good actors. They tend to grow faster.
Okay.
And they need to be picked up earlier. So if we don't start screening until 50, which was one recommendation we saw out there, we miss that window of finding that cancer and actually...
finding it early.
Finding it early.
Okay.
And unfortunately, as many women in their 40s are diagnosed with cancer as in their 50s. If you stop doing mammograms from 40 to 50, you are basically not finding those cancers.
When you say stop doing mammograms from 40 to 50, do you mean somebody gets one at 40, it was clear, so now they say you don't need one for another decade? Or do you mean that we're just not going to screen people who are between 40 and 50 years old?
I've actually seen that as a recommendation. And these recommendations come mainly from a UPTS, the United States Preventative Task Force, which is a non-government body that basically looks at data from all the studies that are done on mammography in the US.
Okay.
And actually they use a lot of, it's mainly US and Canada data.
Okay. So North American, but they're not taking into account European guidelines or studies?
No.
Okay, that's an interesting thing.
No, and they, actually most of the studies have been done on screenings, for instance, from Sweden, where they clearly show a benefit to screening mammogram, finding that cancer earlier. And no one disputes that finding it earlier is better than finding it large and late.
Certainly. And that would make a difference for treatment as well.
Absolutely, absolutely.
So you said younger, maybe not screening younger women as a guideline. What is considered a younger woman?
So in the past, we've screened from age 40.
40.
And women with a higher risk, we've screened them 10 years before their mother or sister was diagnosed.
Who determines the high risk? Are those the general practitioners, the internal medicine docs out there?
Yes, most of the time the family history is going to be something that the doctor is aware of and will say, well then let's get your mammogram a little bit earlier than 40, right?
And in clinical practice, in real time, in the trenches, day to day, do you see differences in the population of people coming to you for screening, or has it not really changed despite the changes in the guidelines?
Actually, most women are still coming at age 40.
Okay.
And I think that it's been so discussed that even though the recommendation may be from their doctor, well, you could probably not do it or do it every 2 years until you're 50, between the age of 40 and 50. Most of these women are actually very well informed, and that certainly the women that come to me tend to start screening around age 40. And the American College of Surgery, breast surgeons,
Sure.
The gynecologists,
Okay.
all the doctors that actually see these women
Mm-hmm.
are very much behind annual screening beginning at age 40,
Got it.
and even younger if they're high risk.
Got it.
But there is a caveat there,
Okay.
because young women have dense breast tissue,
Okay.
and it's easier for us to miss a small cancer in that dense breast tissue
On mammography.
on mammography.
Okay.
So there's a sort of growing trend now towards screening with ultrasound in dense breast tissue.
So using both, or once you determine that per mammography that it's dense or per exam, then you only do ultrasound.
We have to do an initial mammogram
Okay.
to see what the density is like, because feeling the breast doesn't tell us at all. It's
Got
what
it.
you see on
Okay.
the mammogram. So if they have dense breasts on the mammogram, then I will usually have the conversation about combining screening ultrasound with mammography, or even instead of mammography
Now
for that
that's
first
a
10
big
years.
point. Now are you leading the way on this locally?
Very much so.
Okay.
I have to tell patients this isn't a standard of care,
Mm-hmm.
but just from experience of when I find and how I find breast cancers, I'm actually offering that option in younger women screening with ultrasound, then starting mammography at age 40, and even then maybe alternating mammography and ultrasound.
So it's not enough for somebody to come in and say, I have dense breasts, I just want to do an ultrasound, I'm afraid of the radiation from mammography. That's not good enough for you, doing an exam and taking their word for it. You have to determine whether or not they're dense breast tissue via mammography first.
Right, and if they've had a mammogram somewhere else and they know that,
Okay.
that's great information. And then I will have the conversation with them and
Okay.
explain the limitations of mammography, the limitations of doing ultrasound only, which are actually less for me in that young woman. But, we'll explain all of that to the patient, and then we come up with an educated decision on what they're comfortable with and what.
Some people
Yeah.
complain that mammograms are uncomfortable, and I can absolutely assume that they are, or that they hurt when they get them. What about ultrasound? Is ultrasound painful?
No, ultrasound's messy
Okay.
because we have to use
Okay.
gel,
Okay.
but no, it's not painful. There's no
Mm.
compression with ultrasound.
Wonderful.
Yeah.
And just to be certain, there are lesions that you found on ultrasound that you didn't see on mammography.
Absolutely. In
Okay.
fact, on average of all the studies now that have been sort of put together, we're finding twice as many cancers on ultrasound in dense breast tissue, even compared with 3D. So either 2D or 3D mammography still misses cancers half the time.
Let's say that stat again for our audience. You're finding how many more
So we're
cancers?
finding twice as many cancers in dense breast tissue if we do ultrasound at the time of the mammogram.
So Dr. Barclay-White, why aren't more centers doing ultrasound at the time of mammography?
So it's partly we're doing mammography because we've been doing it for a long time. This inertia of changing the medical thinking and
It doesn't happen quickly.
it doesn't happen quickly. Probably one of the slowest moving
Vehicles in
vehicles,
in the United
to
States.
change. I mean, completely unlike IT. It's the opposite to IT, right?
Yes.
So that is an issue, trying to change this inertia. So we've already started talking about, well, the limitations of mammography, which I agree with. We can miss small non-calcifying cancers.
It's an old technology, isn't
Right.
it? This
Right.
is still X-rays.
It's still an old technology. So there are some newer technologies out there that find cancers smaller and earlier, such as whole breast screening, ultrasound, and MRI of the breast.
Okay.
There are some other technologies where we inject a radionuclide, but I'm sort of concerned about that because that's a high dose of radiation.
What's that test
That's
called?
called scintillammography.
Okay.
Um,
And the purpose of that is to have whatever that radionucleotide that go to an area of breast cancer, and then you detect it with like a Geiger counter or
Exactly.
something? Okay.
exactly.
So it's a new use for an older technology?
Yes.
Okay, indeed. But then you're injecting radiation into the person.
Yes.
Okay. What happens when you find these smaller cancers? Does the patient automatically get referred to a surgeon?
Yes, over the years that is definitely what happens. So I may diagnose the cancer with a needle biopsy.
I'm sorry to stop you, but you do the biopsy here as needed.
Yes. So if we find something on mammogram or ultrasound that looks suspicious, we will do a needle biopsy under ultrasound guidance or under guidance of a mammogram. That's called a stereotactic
Right
biopsy.
here the same day sometimes as they get their...
I try and do it the same day if they're not on any blood thinners.
Okay. Excellent service.
And then we get the results the following day.
Okay.
So if it's a low grade small cancer,
Okay.
more than likely they're going to be advised to have a lumpectomy
Okay.
to remove that tumor. So I send the patient with the path results to the breast surgeon, and that's traditionally what happens.
A low grade, so it's not very aggressive, meaning low grade. Small tumor, does that mean under a half a centimeter?
Typically,
Okay.
yes.
What happens if that small cancer is invasive?
So most cancers that we will diagnose on mammogram and particularly ultrasound are invasive tumors,
Okay.
right? So invasive just means all cancers start within the lining of the milk duct.
Okay.
So invasive means that cancer has gone through the wall of the milk duct. That's an invasive cancer.
It broke through. It's capsule, so to
Right.
speak. Okay.
And they can still be very small
Okay.
and very low grade and slow growing, but they
Okay.
present that way.
Okay.
And then there are some other cancers that present with microcalcifications that grow along the milk duct
Okay.
and don't actually go through the milk duct, and that's called ductal carcinoma in situ.
Okay.
Okay, and that's a pre-invasive situation.
Okay.
And patients...
Is that considered a cancer?
Yes, it is, because the trouble is that we know that 30% of them will become invasive, and it's really difficult to know which 30%.
And this is the DCIS that people talk about, or that's the terminology. So if anybody's out there, DCIS, is it considered a pre-cancer or a cancer? Where are we with that?
It's called a pre-invasive
Pre-invasive cancer.
Yes. Some people do term it a pre-cancer,
Okay.
and we know that these women do very well on the whole. So we take away that 30% chance of it becoming an invasive tumor,
Okay.
right, by removing it. So most of those DCISs still undergo lumpectomy.
Okay. For these smaller tumors, I know there's a procedure that you've brought to Arizona called cryoablation.
Yes.
Where does that fit in the continuum? I'm very interested to hear about it. I'm excited about the work that you've been doing. You and I have shared a couple patients. Such an interesting technology. Is it considered a surgical technique?
So no, it's done percutaneously through a little tiny incision in the breast under ultrasound guidance.
In an operating room or just in the office here?
Actually, most people are doing it in an office setting.
Okay.
I'm doing it here in my ultrasound room.
Okay.
So the exciting thing about it is that it is an alternative to lumpectomy. In certain cancers, we have to be very selective about which ones we can treat that way. But a small, less than 1.5 centimeters, which is about the size of a grape, right? 1.5 centimeters, small, low grade. So there's grade 1, 2, and 3. If this is grade 1 or 2, we can do those tumors. With no DCIS, that ductal carcinoma in situ we were talking about.
Okay.
We don't like DCIS because DCIS can be there without us knowing about it.
Okay.
And that's an increased risk for recurrence, right?
Got it. Is there a certain age range of somebody who's appropriate for this treatment?
We, to date, have been doing women over age 65.
Okay.
The recent study that is now coming out, we've rounded the age down to over age 50, which is very exciting for the same low grade, well-acting tumors. So 50 years of age or older now.
With a less than 1.5 centimeter tumor, low grade, without surrounding DCIS
Exactly.
in the area.
Yes.
And is it a single treatment in the office or multiple treatments?
No, it's a single treatment. We basically use liquid nitrogen.
Okay.
We introduce a probe through the middle of the little tiny cancer under ultrasound guidance.
Okay, you said percutaneous, which means
Yes.
through the skin.
Through the skin,
Okay.
we introduce, it's really like having a needle biopsy of the breast. It's no more invasive than that.
Wow.
And we leave the probe in there. Depending on the size of the tumor, we freeze for 6 minutes and then we thaw for 6 minutes, and then we freeze again for 6 minutes, thaw, and take the catheter out, and that's it.
That's the treatment.
And they walk out of here and they go to lunch and they go to the movies. They're all so excited. So it's amazing.
People that are selected for this and are appropriate could have their breast cancer treated non-surgically in the office in the middle of the day and still go to lunch afterwards.
Yes.
What about pain? Is it painful?
No, because the cryo portion of it actually freezes the nerve endings as it goes.
Indeed.
So we use local anesthetic to introduce the probe and position the probe through the center of the tumor. Okay. And then as we start to freeze, the whole area is deadened anyway. So no, not painful.
Okay.
Post pain, so pain, an hour afterwards or whatever, haven't had any patients complaining.
Is it discomfort?
They're aware of it. They walk out of here with a sort of an ice ball, right?
Inside the breast.
They can feel a cold breast that thaws within 2 hours. And then gradually over the next few days, they'll be aware of a lump because that's the dead tissue that we've frozen around the cancer. And that lump shrinks slowly, average 2 years, and you can't feel it.
2 years. So besides the convenience and that it's non-surgical and that it's percutaneous, one of the more exciting things that I understand about cryoablation is that the immune system is involved in the response.
And that's what I'm so excited about.
Okay.
So what happens when we freeze these tumors is the actual cancer cell is still it's dead, but the cancer cell, the structure of the cell is still recognizable by the immune system, and you probably understand this better than I do.
Wonderful.
Yes. But that then, the body, because as soon as we've created that big mass of fat, vessels will come into the area, we create an inflammatory reaction, and the body does its job, which is to mop up the debris I've left there with the frozen debris,
Absolutely.
right?
Yes.
And a part of that is that the immune cells involved in that inflammatory response recognize those dead cancer cells, and they start building up an immunity to them. So there's some really promising information coming out, some in this country, but also in Japan and China, where they're doing a lot more of these, about inciting that immune response. And there have been very well documented cases where patients have had multiple tumors, they've frozen one, and the other tumors have disappeared.
That's wonderful, because that's a wonderful intersection between what you're doing, cryotherapy, cryoablation, and naturopathic medicine, because as naturopathic doctors, we've spent great time researching and understanding and testing and working with patients about the functionality of their immune system. And it's a great intersection for us too, because the patients that I've had who have had their breast tumors cryoablated, we've certainly worked on their immune system, whether we're testing it and then stimulating it and in giving them the agents that they need to stimulate their immune system. It's like about time.
That's exactly how I feel. We've been treating the cancers, the size of a grape or smaller, the same way we were treating cancers that presented ulcerating through the breast skin for 50 years. Yeah. And now that I'm finding them this small, I was beginning to get very dejected that the treatment wasn't changing.
Yeah, we have innate biological responses that need to be engaged. So we know that your first and last response to a tumor is your immune system. The problem is why did the tumor grow? Did it masquerade itself so the immune system couldn't see it? Was there something impairing the immune system to begin with? Is there something genomic which impairs the immune system? We don't necessarily know the answer to the question because the tumor is here presenting to her, but cryotherapy can uncloak that tumor for the immune system.
Yes.
And so as naturopathic doctors, if we can help the immune system be as strong as it can be, whether it be by diet or lifestyle, mental, emotional issues, removing a toxicant that is known to impair the immune system in the patient's environment, or by use of supplementation, and combine it with the cryotherapy that you're doing in your office, I'm looking forward to a very useful therapy with people with early stage cancers.
Absolutely. And it's so much less daunting. Mm-hmm. A lot of patients won't have a mammogram, A, because they're worrying about the radiation, which is they shouldn't be worrying about that. But a lot of patients don't have a mammogram because if I find a small tumor, they're worried about the treatment.
Got it.
And if you can now offer something so much less formidable to them, I'm hoping that it will encourage people to try and find their tumors earlier.
But the cryoablation at this point is really open to somebody who's who's over age 50. So
Yes.
for the younger, earlier detect, even if it's a small, low-grade tumor, the standard of care is still surgical lumpectomy.
It is still surgical lumpectomy, and like all things, this is so new in the breast. We've been using it in other places. Actually, prostate, which to me it seems much more formidable and invasive than the breast. But I guess that's where I come from. But I've forgotten what I was going to say.
I'm certainly hoping that even though it's been recently introduced, that this is one that makes so much physiological sense, helps with cost containment, reduces stress and anxiety from the patient, that this is going to move along as quickly as it really needs to, which sounds like it needs to move pretty quickly, be brought to other age groups, making sure that it's safe for people. And it's exciting that you've brought this here to our local Phoenix metropolitan area.
Well, thank you, Dan. And I'm so pleased that you're so supportive of it, and it just fits with what you do. In fact, when I started doing it, the first thing I did was come around and tell you about it, right?
Remember our meeting.
Yeah, that's right.
Well, thank
that's
you.
Right.
Thank you for being part of the show today. I appreciate it. Like I said, I appreciate all the support and the work that you've done for the community. It's a privilege to be your colleague. And for Ad Hoc with the Doc, this is Dr. Dan Rubin with Dr. Belinda Barclay-White of Breastnet.
Thank you, Dan. Can I say likewise? I think you've done a huge amount of support for the community as well. I think what you do is wonderful.
Thank you.